Very good afternoon to all our webinar participants and especially our speaker for the day, Dr. Galit.
Thank you. Thank you very much.
So, we are very fortunate. Dr. Galit is here with us to talk about big data, and now the knowledge about it is very much important for all of us, be it epidemiology, clinical research, or any field for that matter. Madam is Associate Professor and Head in Big Biomedical Data Research Laboratory. She is a biostatistician and an epidemiologist, specialist in oral medicine. She's a member of the Hadasa Medical Center Helsinki Committee and the past president of Israeli Society of Oral Medicine. So I've personally heard, seen your work, impressed with everything that you've done, Dr. Galit. And this is a big opportunity for all of us of the public health dentistry fraternity to learn from you. That was our only motive, that pan-India people can hear, understand, and use it for their benefit in whichever field they want to work on. So thank you so much. At the same time, we would also like to thank the administration AIIMS director, Sir Dr. M. Srinivas, for allowing us to also use our AIIMS YouTube channel for the live streaming of this webinar today. Our chief, Dr. Ritu Duggal Madam, who's always been a source of inspiration to conduct such academic activities, and all our colleagues who worked for the vision that let us do something for the whole public health dentistry fraternity in India. So with that, I would request Professor Galit to kindly start with the webinar. Thank you.
Thank you very, very much. I would also want to start with thank you for my dear friend, and I really appreciate you, Professor Dr. Harshpriya, which I know from her she's very, very active in the e-oral health network of the IADR, which is actually a network that is dedicated to e-oral health, big data, studies of teledentistry, etc. So I was very impressed by her activity there. I think she represents wonderfully India and public health dentistry in India. And we thought about collaboration. So I thank you for inviting me today. And my lecture today will focus on big data studies in dentistry and craniofacial research. So first I will start with a brief introduction of my laboratory and what I'm going to discuss today. First of all, you can scan the barcode of many of the things that I will show you here. Here is the laboratory website where you can learn about the project, the running big data projects in the laboratory. So you can learn about the students, about the projects. I will talk today about two main projects that I'm involved, big data projects. The first one is the DOM study, Dental Oral Medical Epidemiological Study. The second one is called Rheumatic Monitor. I will not have time to discuss the UK Biobank project, which is also a big data project, but I will say a few words about it right now because we are a consortium of doctors in different fields. I am a specialist in oral medicine, and I'm also a biostatistician and epidemiologist. And most of my studies are related to the association between systemic condition and dental and craniofacial conditions, because I believe in a holistic approach to look for the whole body as one thing. So our consortium is composed of doctors in many fields. There are doctors which are cardiologists, ophthalmologists, rheumatologists, etc. And we gained access to the UK Biobank data and working on developing machine learning and AI algorithms to predict chronic diseases, including dental and craniofacial things. So for those of you who are interested to learn more about the laboratory, more than I will have the time to speak here today on the limited time of the lecture, you can go and visit the website. So let's start first of all, I know this is the buzzword called big data. Yes, it's a buzzword. So I want to start from a small introduction about what is actually big data. So actually, the definition has expanded over the years. We're talking about the V's, and we started from 3 V's of big data, which is actually volume, velocity, and variety. And most of you, if you will talk to people and ask them what is big data, they will mainly talk about the volume of the data, which is only 1 V, the volume of the data, which means huge size of data. But this is not the only V, because data comes also in variety, velocity, and other things. Then they expanded the definition to include 4 V's, and then it was also expanded to 5 V's, which also include the value of the data, and then expanded it to 10 V's. And now there are more than 56 different V's for the definition of big data, which you can see volume is only one of them, but there are also other characteristics of the big data. And I'm sure that, with time, there will be more and more and more definitions and more V's that will be included. So when we talk about the source of data, we are now talking about what we call the Internet of Things in the world, where data come from different sources. Data come, all the big companies, they use customer data, they use retail data, medical data, military data, and actually data is gathered all the time while you're at work, while you sleep, while you exercise, everywhere. And all this data is actually data that we can achieve and learn from. And this data is connected in the Internet of Things, IoT, and it is used to learn mainly for what we call behavioral targeting. That means that all our data actually tells a lot about us and helps people use this data to better sell things for us or learn about us. So everything is known, where we travel, we use the internet to buy tickets or to use hotels. Our relations is discussed in social media, hobbies, actually shopping, political views, everything is actually listed. So they actually have a profile of every person, which can help to do what we call the behavioral targeting. So the question is whether medicine can learn from these big companies like Amazon and Netflix, which use this can all these big companies, can we learn from them, from Amazon, from Netflix, where they use all this data to do, they use it to know for their own sake, but medicine can learn a lot about it. So I always like these slides to show because I think it's very provocative and it makes you think about questions. So the question in this Time magazine was, can Google solve death? So this is actually, whenever I see it, I think how mind-blowing is this thing, can we solve morbidity? Can we use the data to give better medicine to people? If somebody can do it, this is the big companies. Google is a platform. They also have Google Health. So what is the data that we have in the medical field? Now, the data in the medical field is actually huge. We can use genomic, transcriptomics, proteomic data, microbiome, metabolomics, epigenomics, and everything. And also, we can use data, information technology systems, infrastructures. We have all what we call electronic medical record of the patient. That includes all the patient care information, including imaging, pharmacy, all the medication the patient has gotten, radiology, and laboratory information. All this is included in the health records database in the what we call EHR or AIIMR, electronic health record or electronic medical record. And these things can be combined to create actually a huge database that has a lot of information about people that can help us learn about their medical dental conditions. Now, what do we do with all the data? Okay, we gather the data and then we have to analyze it. And when we're talking about analyzing, we start from what we call, basic statistics, which you're all familiar with. But now there are more techniques, all called AI. And within the AI, there are many methods, including machine learning algorithms, neural networks, deep learning. And all these new technologies are helping us to analyze data in new ways that help us to gather more information. Now, data, when you are working in the big data field, it comes with challenges. It's not so easy to do it. Otherwise, everybody will be able to do it, but it's not easy. First of all, challenges are related to each one of the V's that I was talking about, handling a large volume of data, handling a variety of data, some coming on from X-rays and some coming from EMR. This is not easy to do. Then we have the data. The other problem is processing the data. Because when you get the data, first of all, you have to mine it, okay? And then you have to sometimes clean it. You have to handle missing data. Sometimes the data is in some things is missing. Then you have to aggregate the data to make it meaningful, to integrate the data. I call all these phases harmonization of data. Before you enter and start, analyzing the data or choose your model or models. And I will show you that I use several models because during the years, I've stopped believing in one model. So I always apply different methods for the same question. I will show you in this lecture, I hope, that actually all these things are necessary because the first thing I teach my students is garbage in, garbage out. If the data is not harmonized, then this is the problem. I will not have time to speak about it, but every medical system is working in a different coding system. So if the classification system is different between different sources, it could be a problem. For example, if I take a laboratory exam, which is written in a milligram percent, and somebody else is checking this in a milligram per deciliter, then we have to know that we use different methods to evaluate parameters, and we have to encompass this. So using standardization and international guidelines for diseases, the medication, etc., is crucial if we want to work on data. So then we come to the third problem, which is the management challenges. Now, when we talk about the management, we're talking about how to secure the data, privacy problems, privacy that related to information sharing, because sometimes we want to share information with other sources. And when we are talking about information sharing, we are using, for example, I don't know if this is a lecture on its own, but maybe you've learned about federated learning. federated learning is a method where everybody is doing his own algorithms, and only the algorithms are shared and not the data. So I give you the results of my algorithm, you give me your results of the algorithm, but the raw data is actually not shared. This is called federated learning. This is a lecture on its own. So there are many ways to overcome these problems of data sharing. And of course, we have to make all the operational costs of this, because you have to have the team that works, that needs expertise, the team that comes with medical team, IT teams, bioengineering team, and all these things are challenges that needs to be taken into account when we are talking about analyzing big data. So now, after this, brief and short introduction about big data in general, I want to talk about the biomedical data in dentistry and oral medicine, which is our field. We are public health dentistry, so we are interested in our field. So when we talk about big data in dentistry in general, we can gather data from all different sources. First of all, from the pre-visit, from the clinic visit on its own, and then from the post-visit things. So this is a recent paper published, and he is actually trying to summarize what we can do. So in the pre-visit, we can use alerts and reminders to the patient. We can do things how to reduce pain, and of course, educate the patient, do pre-screening, do service before the patient even enters the clinic. So this is actually a huge topic now, teledentistry. And if you will be interested, you can come and join the ER Health Network, working a lot about the teledentistry in general. In the clinic on its own, this is we can use decision support systems, which helps the doctor to decide what is the right diagnosis and how to analyze data of a specific patient and get into the proper diagnosis. We can do risk assessment. We can monitor vital signs. We can use it for pain reduction. And of course, to educate the patient again, to screen the patient, again, to use surveys. So, and of course, in the post visit, we can also use the same things can be done. Now, what are the devices that we can use for to gather data, to collect data, etc.? So there are of course we can use screens, iPads, etc. We can use the intraoral scan of the patient. All these things can gather into the iPad. But we can also use devices like sensors that are can be located in toothpaste, in the toothbrush, in the teeth, etc. All these places can be used to gather information through sensors. So we will have what we call smart brushes, smart paste, smart mouthwash. All these things are actually can help us to collect data and to collect information that can be actually sent into a cloud about a specific patient and help us monitor and get information and get data. Data can be also being not only on the hard tissue of the mouth, like the teeth, but it can be it can be in the soft tissue of the mouth, like a patch in the mouth that can collect the data and information and be a sensor on its own. So both the hard tissues and the soft tissues of the house can use to do actually. So actually, we can have what we call, this paper summarizes the Internet of Things in dentistry. So gathering data from different sources, as was shown before in general, can be also done in dentistry. So now, after this information, I will start talking about my research. And one of the reasons that I come for these lectures around the world is because I like collaborations. And for those of you who will find it interesting, I would really love to collaborate. For those of you who want to do research on specific topics, I will show some of the research that we do. So I encourage each one of you who is interested to collaborate to contact us. This study is called the DOME study, Dental Oral Medical Epidemiological Study. This is a very large repository that I established 12 years ago. And the protocol and the study methods of this paper were published, as you can see here, in the Journal of Methods of Information in Medicine. This is not a dental journal. This is an informatics journal in medical informatics. You can scan the barcode if you want to get the full paper and read the full paper. But this paper, I dedicated this paper to explain all the protocol and all the methods for how this repository was created and what does the repository includes. So the DOM study is actually now composed of two databases. The first one includes, as you can see here, 200,000 subjects. And the second database is almost 1 million patients now. It's a little bit more than written here. And the second database is actually a longitudinal database that collects data for 10 years, as you can see here. This database includes sociodemographic data, medical data, and dental data. All this data are actually staying in one database. So how does it go? This data was collected from military personnel, it's mandatory in Israel. So there are several databases which are actually operational systems that work. The first one is called CPR. CPR stands for Computerized Patient Record System, and this is the medical record of the patient. This includes all the medical examination the patient is doing, laboratory, etc. The second database is called DPR, which stands for Dental Patient Record, which is actually the dental record of the patient. And the third one that we collected is called the Central Sociodemographic Database, which includes sociodemographic databases. There are other databases that were not included in the DOM repository. So what happens that each of these operational systems is actually updating a data warehouse. DWH stands for data warehouse. This is the Oracle data warehouse. And it updates them in ETLs, which are daily processes of updating the data. Suppose you are going now to the doctor, so at night, each night, the database is updated with new information about you since you actually entered the doctor and now you gathered new information like examinations, like laboratory, etc. So through these ETL processes, each of the databases, each of the operational sources is updating the data warehouse, and the information is collected in one data warehouse. And from this data warehouse, we extracted all the data for the DOM study. So what is actually the data that is included in the DOM repository? So first of all, the DOM repository, as I told you, includes now more than 700 different variables. And variables are actually divided into 5 main categories. First of all, we have baseline data of the people who entered the cohort. We have their sociodemographic, medical diagnoses, blood tests, and general physical tests and habits. Then we have the central demographic database. This is the second bulk of data, which includes lots of sociodemographic data. And data does not come from the patient. You know that if you ask the patient about their a socioeconomic status, etc., they can it can be biased because because of what we call Hawthorne effect, which people are actually wishing to look. They want the interviewer to think they are better than they really are. So there is a lot of information bias when you collect the data from the patient. So all this sociodemographic database is coming from the Ministry of Interior in Israel. This is objective data which does not rely on the patient. We gave the age, sex, educational level, IQ test. Each of the people who entered the cohort, they're going through a battery of psychometric tests, which produce an IQ result of each one of them. We have the socioeconomic status. This is actually very interesting. In Israel, Israel is categorized to 10 categories according to the socioeconomic status based on the family income, education, etc. From 1, which is the lowest socioeconomic status level, to 10, which is the best socioeconomic level. So we have the data of both the locality of residence of the patient, and then we have the socioeconomic status according to this category. Israel is an immigrant country, so we have both the origin and the birth country. Origin is the origin of the parents, where their parents were born, and birth country is of the patient. We have the religion and municipality of the patients. We have all what I told you before about the CPR, which is the third bulk here. You can see it, and the CPR is the central patient record, which is the medical record. It includes medical diagnoses, blood test results, general physical tests, health-related habits, and medical doctor diagnoses and examinations. Regarding the health-related habits. Health-related habits are the only habits that we collect from the patient because we have to rely on their reports about smoking, about alcohol consumption. This is, of course, prone to information bias, but we don't have any other choice mainly because of the information about past smoking history and past alcohol history. And although we have a lot of data, I always write in my paper that there are unknown confounders like exposure during uterus, during the pregnancy, and during childhood. So there is a lot of information that can affect the patient, and we have to know, but this has to be collected. The first bulk is the DPR, which stands, as I said before, for dental patient record, and it includes dental diagnoses like periodontitis and like all the oral lesions, etc. But it also includes all the procedures that are planned and those who are actually delivered to the patient. Because there is a difference. You can have a planned dental treatment, and then the patient is not doing the whole dental treatment he needs. He does only half of it or some of it. So we have both the planned and delivered dental procedures. For each dental procedure, that means each, I will show you in a minute all the definition of the dental things. And then we have, of course, dental habits such as toothbrushing, cardiogenic diet consumption, and sweetened beverage consumption. And we have the visit to dentist, visit to dental hygienist, visit to specialist in dentistry, etc. The fifth bulk is called what you see here, Melanie. So what is the Melanie? Melanie, you can read about it. It's written over here downstairs. This is a survey called Metabolic Lifestyle Nutrition Assessment in Young Adults, or Melanie. This is a survey which is done every 3 to 5 years to the patient. So what happened that every depending on the age, so from the age until the age of 35, they have to do it every 5 years, and after the age of 35, they have to do it every 3 years. So in this survey, they go through a battery of tests, which includes, as you can see here in the bottom, They do blood tests. They get through a general physician examination. They go through a very detailed questionnaire. So the questionnaire is a nutritional questionnaire about habits, about activity, and then finally medical diagnoses are made based on all these tests. So it usually takes several hours to do these tests, and they have all the information. So the Dom repository includes all this data in the database, in one database. So for each patient, we have the data which was collected from its baseline, the sociodemographics of the patient, the medical, the dental, and the Melani, which is the questionnaire and all this battery of tests of the patient. Overall, as I said, all this information, and I'm showing only some of it, it is more than 700 different variables. Now, what I talked before about how important it is to have standardized terminology for all the information which is gathered, because otherwise we will not be able to share this information with the world because the data is not standardized, we cannot even publish it. So this, you can see, is the nomenclature of all the dental procedures in the dental patient record, in the DPR. And here you can see on the left the DPR code and the nomenclature. And all this data is equivalent to the American Dental Association CDT, which is the current dental terminology called CDT. And these data are actually the same. So we have, as I said before, about each of the procedures which are done. You can see here amalgam surface 1 surface, amalgam 2 surfaces, amalgam 3 surfaces. So for all these things, we have both the planned, if I was planning to have 3 amalgam, one surface amalgam restoration, and finally the patient only has done 1. So I have 3 on planned and 1 on delivered dental procedures. So this is extremely important. What about the medical diagnosis? So the medical diagnoses, we are using the ICD codes, but we also created what we called a complex definition, a variable definition. What is a complex variable definition? We analyze the data both according to the ICD code of the disease, for example, hypertension, diabetes, hyperlipidemia, but because we want to avoid false positive, we are also giving for each one of them an algorithm, which is actually saying that the patient is only hypertension if he is according to this complex definition. For example, let's take hypertension. So you can be somebody who is hypertension if you have this code, actually, but not only the code, you have to have at least one result of blood test that is either one measurement higher or equal to one thing, or 2 measurements equal or higher to higher values, or 3 measurement, or you are getting a treatment. You are actually prescribed an antihypertensive medication for a period. So I will call you hypertension only if you are standing for this very strict definition. And this is actually to reduce the mistakes, to reduce the false positive rate. And we are always analyzing the data both according to the ICD code, and then we are also analyzing the data according to this strict complex variable definitions. And we are comparing our data because certainly that as I said, when you are working on large databases, you have to be very, very careful that you will not mistakenly think that somebody, it could be a mistake, or it could be somebody, somebody with hypertension who is not prescribed any medication can be patient under evaluation, which is only suspected for hypertension and not having hypertension. Once you have a diagnosis of hypertension, usually will be prescribed by chronic medication or have at least be tested for high blood pressure measurements. Now, these are some of the papers that were published from the DOM study. As you can see, many of these patients are concerning the association between dental condition and medical conditions. I will talk briefly about some of the papers that I think are important to mention here for the public health audience. But I want to focus first on what on the left. Here you can see a paper that says entitled Dental Cluster versus Metabolic Cluster. And this paper is very important for me because I think that this paper is actually summarizing the main ideas or the main concepts of the DOM repository. What do I mean by dental cluster and by metabolic cluster? You know that lots of time when you go to the dental literature, you find lots of paper about the association between periodontitis and diabetes. You find thousands of patients discussing this topic, periodontitis versus diabetes. And I must confess that it is very hard for me to understand these papers. Why is it so hard for me? Because of the fact that diabetes is completely different type 2 diabetes. When it is standing alone, diabetes standing alone, or diabetes is part of the metabolic syndrome. As you all know, the metabolic syndrome is composed of obesity, abdominal obesity, hypertension, hyperlipidemia, and diabetes. So a patient with diabetes is completely different from a patient with any combination of the metabolic syndrome. This is why the metabolic cluster is extremely important. Also, periodontitis is also part of the cluster because periodontitis, which is standing alone, is completely different than periodontitis with 2 root canal, 1 restoration, 1 implant, etc. Every patient has a different puzzle, a different dental condition. So when you're talking about periodontitis versus diabetes, you're talking actually about the dental cluster versus the metabolic cluster. I want to know what else does the patient have in the oral cavity besides periodontitis, and I want to know what other metabolic conditions the patient has besides diabetes. So this is why big data is so important, because I think that most of the studies were unable to actually see this data because they didn't have the data, they didn't collect the data, they only focused on the periodontitis and focused on diabetes, and they were not actually looking on the whole cluster. And when I'm talking about the cluster, I'm talking about the cluster itself, that means the components of the cluster, but I'm also talking about related conditions such as you can see here, sleep apnea and fatty liver. And we're also talking about all the consequences of metabolic syndrome, such as cardiovascular disease, etc. So, so one thing of the DOM study is actually its comprehensive, how comprehensive it is. The second thing is its unique database, the comprehensive database that includes data that enable us to actually cross-reference the dental cluster versus the metabolic cluster. And the third unique thing that we do in the DOM study is actually the analytical approach. You're all public health specialists, dental public health specialists, and my approach over the years have actually evolved. So in a way that I have stopped believing in using only one model or one approach, because I know that every approach has a pros and cons. So there is nothing perfect, okay? So what I want to do most of the time is to use several methods to analyze, to approach this thing, And usually I've not abandoned the classical statistics, but I use both statistical and machine learning analytical approaches. So my first step always is to use p-variate statistical models analysis, classical statistic, because as I told you before, harmonization of data is extremely important. Why is it so important? First of all, by doing this classic statistic, baseline statistics, I clean the data. Because if I see that the data includes things that are biologically unacceptable, I can clean this. For example, if somebody is coming and I see that he is 4 meter high, this is impossible biologically. There is no one on earth with a 4 meter high. Or if somebody's weight is biologically unacceptable values such as minus, there is no such thing. So doing any algorithm before the data is cleaned, and I'm not talking about outliers because I love outliers actually, because people can be outliers. But what I don't agree that will exist in the database is outliers which are actually biologically unacceptable. As you all know, as public health dentists, we are talking about what we are calling borderline outliers, which are 1.5 from bigger than the infantile range, and real outliers, which are 3 times bigger than the infantile range. But I don't clean these outliers. I only clean those who are biologically unacceptable values. The next thing is before I'm doing a multivariate analysis model, and step number 2, I assess for what we call collinearity between the variables. As you all know, what happens in big data is that we have a very, very large power because the N is very large. So the power is huge. If you're doing a sample size calculation, you will have a very large size because of this large database that you have. So what happens is because of this huge power, you can detect very, very weak associations. Associations which are clinically meaningfulness, they have no clinical meaning. You only detect them before because you have a huge database and because of the fact that you have a huge power. So collinearity becomes extremely important, and so is the p-value, because you cannot use the p-value of 5%. This is for you will find even weaker associations. So I'm using 1% or even a promille. Because otherwise it will not. This is not good for big data studies. And also I assess for collinearity. So what is collinearity? When we are talking about the association between the independent variable and the dependent variable, this is what we are looking for in our model. But there can be also association between the independent variables, and this is impossible in a statistical model. In a statistical model, we have to rule out any collinearity with the independent variables. We are doing a test such as variation inflation curve or VIF and tolerance, if you know this test. And here again, we have to choose a very strict cutoff, because usually when you are doing statistical models, you can use the cutoff for the VIF can be 5 or some say even 10. But I usually take for the model 2.5 or 3 as a cutoff to rule out collinearity. Then we're going for, and I didn't show here, we also have to use things to reduce the false detection rate, because we're doing sometimes multiple comparisons, because we're doing so many comparisons. We have to reduce them by correcting for multiple comparisons using methods such as Biomedical or other statistical methods to reduce the false detection rate. And only then we can approach the multivariate models, statistical models. And when we finish the statistical models, as you can see, this is a long process. we are gaining more models such as machine learning algorithms. And now we're in step number 4 and 5. Now, when we're using statistical models, there is always one model, which is usually the model, the bivariate models, the multivariate models, etc. So we have different models for statistics, but we have to also use different algorithms for machine learning because we cannot rely on one algorithm. Each of these algorithms is based on another a way of working. Some of them are decision trees, other works other ways. So, for example, I will use some gradient boosting, such as x-base boost, and then do what we call sensitivity analysis, which is actually applying the same thing on different models, such as random forest, information gain, etc., whatever you want. So what is actually working? How do we build these models of machine learning? There are different algorithms, as you can see, but what happens is that we have the input data. Data is, of course, as I said, cleaned, and we remove redundant feature. We do what we call, this is all steps are called actually pre-processing. And then we divide the data into a training data, where the algorithm is learning based on its training data, and a test data. That after the algorithm has learned about the training model, he can apply it on the test model. And as you can see, there are many algorithms that can be used. And what the algorithm is actually trying to do is different tasks. And hopefully I will have the time to show you some of the tasks. For example, one task that can be done by algorithms is classification task. That means that the algorithm has to choose either somebody is sick or not sick, either is 1 or 0. Other tasks can be clustering. We don't tell the algorithm to choose between sick or not sick. We're just giving him the whole sample and telling him to divide it into clusters. How many clusters does it see? He sees 3 clusters, he sees 2 clusters, etc. So there can be different tasks that can be done. So the model is actually, when he classifies things, he does what we call feature selection. He's actually selecting the most important features according to the model, and he's ranking them from the highest ranked feature. Feature stands for variable. In the machine learning world, we called the dependent variable target, and we called the independent variables features. So he's doing a feature selection, just like the statistical model, where he can tell us which feature is more important than other features. And we can see the most important features. So we have, as I said, different tasks. And once he has learned from the training test, we can apply it for the test and see what we get. So now that I talked briefly about the uniqueness of this database, I want to show you some of the papers. You can go, and of course this is a lecture, so I will not have enough time to go through all the papers, but you can scan the barcode here, and I will talk about this study, and I will talk about each of the studies that I will show you. But if you want more information and read the full paper, you scan the barcode and get into the full paper. So this paper was actually published last year, and it is talking about periodontitis with metabolic syndrome, statistical and machine learning analytics from a nationwide study. So this database was actually, we took a sample of, as you can see here, 57,496 dental patients. Patients are actually in the database are young to middle-aged adults from the age of 18 to 50 years old. And the prevalence of periodontitis in our cohort was almost 10%. This was the prevalence of periodontal disease in our cohort. Then we have done actually a bivariate analysis and chose all the factors, all the parameters that were statistically significant association with the periodontitis. But before we move to the model, we have done, as I told you, collinearity statistics. You can see it here. And we wanted to see if there is any collinearity. Now you see here that the final parameters that were chosen were not collinear, because you can see here that the VIF here in this column, the VIF is less than 2.5, which is the cutoff, very strict cutoff that was chosen. Okay, and then after we did a bivariate analysis, collinearity analysis, false detection rate reduction, we go to the final statistical model, which is a binary logistic regression. And from lots of variables that were statistically significant, we were only left with few statistically significant variables, which actually establish the profile of the patient, which is vulnerable to periodontitis. Now, there are known features such as age and rural locality and smoking and less brushing teeth and consumption of ketogenic diet. But interestingly, there are three things that I found very, very interesting. The only systemic variables that were statistically significantly associated with periodontitis were obstructive sleep apnea and non-alcoholic fatty liver disease. Diabetes was statistically significant in the univariate analysis, did not retain its statistically significant that means that when you look at the whole metabolic cluster, diabetes and periodontitis are definitely associated, but there are other things in the metabolic syndrome which are very, very important also. The second thing that we saw, as you can see from the odds ratio, which is less than 1, that people with periodontitis had less caries. And the mean number of untreated dental DKTs was lower in these people. And then we moved to a machine learning algorithm. We performed several algorithms, and this was the best result that we could see. And what's interesting here, you can see that what the algorithm did, it does a feature selection, and the most important parameter, according to the machine learning algorithm, was age. While the target was periodontitis, we were actually trying to look for periodontitis, what's important for periodontitis, ketogenic diet, smoking, and sex. But interestingly, regarding the systemic conditions, he pointed out on obesity and then also on obstructive sleep apnea and non-alcoholic fatty liver disease, while diabetes was not even among the 10 most important things. So again, both the statistical model and the machine learning algorithms pointed out on these specific parameters. Also, mean number of untreated DKTs was also one of the first things after well-known confounders. And this points out the things that were not analyzed before, and I dedicated 2 papers for this that were published in the last years. That these are the students, the wonderful students that were involved as their thesis. This was the part of their thesis in the faculty. One of them is Noya, you can see her here, and we worked on obstructive sleep apnea, metabolic dysfunction, and periodontitis. And this is Doron, a student. Now both of them are dentists, doctors. This was done while they were already students, which worked on non-alcoholic fatty liver disease. And why is it so important? Because things have changed over the time. And several years ago, actually 4 years ago, there was a new definition for non-alcoholic fatty liver disease. A group of experts from 22 countries in the world, an international expert consensus statement, stated a new definition for non-alcoholic fatty liver disease, and it is now known as metabolic dysfunction associated fatty liver disease. And that means that they now recognize, you can see here in the learn, MAFLD, stands for Metabolic Dysfunction Associated Fatty Liver Disease. This is the new name of non-alcoholic fatty liver disease. And why is it so important? Because they now recognize in this name that fatty liver is actually the metabolic syndrome manifestation in the liver. The metabolic syndrome is actually manifested in many tissues in the body, and one of them is the liver. So instead of calling it non-alcoholic fatty liver disease, which means nothing, they want to emphasize that this is actually a manifestation of the metabolic syndrome in the liver. And what they do is actually they start their definition by actually seeing if the patient is obese or has normal waist, and if the patient is having diabetes. So diabetes is extremely connected, and also obesity are extremely connected to the metabolic syndrome and to the non-alcoholic fatty liver disease or metabolic associated dysfunction. And we know that there is also a bidirectional relationship between obstructive sleep apnea and metabolic syndrome, where actually obesity and type 2 diabetes are associated with sleep apnea. So this is actually a very complex thing. And now I want to show you from this concept what we now think is the concept of understanding of processes in the body. This paper was published in the JDR, a very important journal in dentistry. It was published 2 years ago, and I think this is a very nice paper that you should also take and read it. And I will explain briefly the concept described in the paper. The paper is discussing periodontitis and accelerated biological aging. And what is interesting in the theory is that when we are looking at people, there are some people who look very old, and some people who look very young and feel young and also very healthy. So there is also what we call healthy aging versus accelerated aging. And what we know today is that it all starts from the yellow part, which is the intracellular level. And there are processes called immunosenses that you can see here. And this is intracellular processes within the cell that happen when we age. And these things include the telomere become shorter, attrition of telomeres, the mitochondria become dysfunctional, there are epigenetic alternations. All these things happen, oxidative stress, of course. All these things happen within the cellular level. And then we move from the yellow part to the orange part. And the intracellular level processes are manifested as markers in the blood. So after some time, this low-grade inflammation, which happens in the body in the immunosenses processes, makes the CRP, C-reactive protein, which is associated with inflammation, be elevated. The LDL is elevated, the blood pressure is elevated, all the cytokines are elevated, hemoglobin A1C is elevated, so fibrinogen is elevated. And after this immunocellular level in the yellow and the processes, the markers, which are elevated, and the orange part is called inflammaging. This is also a buzzword. You will hear a lot of papers discussing inflammaging, which stand from aging and inflammation, and this stands for the low-grade inflammation throughout the life. So they coined the term inflammaging. And finally, after we have the yellow part, which is the immunosenses, which is the intracellular level, and then we have the inflammaging, which is the orange part, we have finally the red part, which is the phenotype, the clinical phenotype as diseases. And this is called all the age-related diseases because of these intracellular processes, because of all these elevated markers in the blood. We are having all the diseases associated with age. Then we have the metabolic syndrome and arthritis and malignant cancers and chronic obstructive pulmonary disease and diabetes and chronic kidney disease and frailty and osteoporosis and also periodontitis and tooth loss. So here you can see why it was so important for me to discuss dental cluster versus metabolic cluster. Because what do you mean by the association between periodontitis and diabetes? These are only 2 points in this large picture. 2 points. We are actually talking about periodontitis and diabetes being part of a larger syndrome, which is the age-related syndrome, which includes many other diseases. So this holistic approach is actually very, can be only achieved through big data studies because we have to have all data about all these markers, all these age-related conditions, etc. So when you see it, you understand that it is important to control for risk factors and many other chronic conditions that happen. So the conclusion from this paper, specific paper, is that assessment should consider all the risk factors for periodontitis and adjust for the treatment approach accordingly. And the other thing is that we have to have more studies that combine statistical and machine learning algorithms so we can learn from these things more and more. Future directions on this part are works of the 2 students of mine. The last one, Dr. Adiel Cohen, is actually a gynecologist. He's not a dentist, he's a gynecologist, and he's working about infertility and pregnancy outcomes and their association with systemic condition. And Dr. Itai Eisenwood, which is actually working on periodontal disease in different ethnicities, with checking ethnicities coming from different areas around the world and checking for differences in morbidity and mortality among these ethnicities. Now, through this process of working on this big data, we have established a dental inflammation score. So a dental inflammation score is just I will stop for a minute. I will ask you how much time do we have?
Galit, we have another 20 minutes.
Okay. Thank you very much. Thank you very much. It is important for me to know, so I can. 20 minutes is great. So we established a dental inflammation score, which is actually based on the CRP, C-reactive protein level. And we computed this dental inflammation score based on several tests. If you are interested to see how we computed this dental inflammation score, you can see it in one of our papers. So this is important because, as I told you, inflammation in the body is extremely important. All these things are connected to each other. It is also important for me to show you things about caries. Not only periodontal disease, I've worked a lot about caries, and this paper was actually published in 2022 about the association between BMI, body mass index, and caries using the DOR studies. And this is, as I said, extremely important because, as you know, we have a pandemic of obesity in all around the world. And diabetes and obesity are now considered diabesity pandemic. So we took patients with different BMI categories. Underweight, as you can see, is BMI less than 18.5, normal range of weight, overweight, and obesity. And also within the obesity, there are different categories. And we have seen that those who were underweight and those who were obese had higher levels of caries compared to the normal weight and slight overweight. And again, we have used very sophisticated statistical models where we have done it in several models when we adjusted each time, we adjusted for a different variable. The first model is unadjusted, and then we adjusted for age and sex, sex, and education. So finally, we ended up with 16 model, adjusting for a lot of variables, and we still could see that overweight, underweight, and obesity were positively associated, were statistically associated with underweight and obesity after this. We also used, as I showed you before, machine learning algorithms, and after well-known, this was done twice. First of all, we took dental caries as a dependent variable in this model, and for dental caries as a dependent variable, after well-known risk factor for dental caries, such as socioeconomic status, toothbrushing, breast country, sex, and consumption of sweetened beverage, the first systemic condition was the BMI category. As you can see here, the first systemic feature. We have also done the same thing for obesity classes. And we've seen that obesity class 1, obesity class 2, obesity, this one is unpublished yet. We have to publish it. The other one was published before. And we see here that there is a dose response curve where the higher the obesity class is, the higher the caries is. And we have done another model, another machine learning algorithm where you use obesity as the dependent variable. And as you can see that when obesity is the dependent variable, brushing teeth and caries were also very important features. So as you can see, BMI and caries are important, and we have a dose response curve. The higher the BMI, the higher the dental caries is. This was also, again, a lot of information. It was published in the in websites and other people, and even in Israel. Now, I will briefly go through this. These are my students, and I will, in the few minutes that I have, I will talk about another project that I have. It's called Rheumatic Monitor, which is intended to focus on patients with rheumatological conditions. There is also a website, the Rheumatic Monitor study, where you can get into the website and learn. We have data coming from electronic medical record, and this is the website of the Rheumatic Monitor study. You can see a lecture, and you can scan the barcode and get into the website of the Rheumatic Monitor study. And we started with rheumatological condition and association with craniofacial condition because they are very prevalent, that they also have craniofacial manifestations in salivary gland, in the TMJ, and other areas in the body. And we wanted to see if we can actually monitor patients. Patients are very different. This is what is personalized medicine. What is the patient that we're looking for? You know, is it a man, a woman, all these things are very, very nice. This is a very large team working on the project. And what we did, we developed an app. Another very important information gathering is using applications. So we developed an app for Android and for iPhones. And as I told you, we can gain information from sensors. So the application is connected to bracelets, and the bracelets connect the number of steps, the walking distance, heart rate, sleep quality, and even GPS data. So in the website, you can see all the guides for Android, guides for iPhone, and here you can see that patients can have all their pain reports. They can go and look at a specific area and say where it hurts, and you can zoom in and zoom out. You can rate the pain on a visual analog scale. You can see your reports. You can answer data about your medication, about your nutrition, about your exercise in a Google manner. You enter the word and it finds it. So actually, the app and the sensor data gave us a lot of information about patients. So we have, this is the complicated architecture composed of the data coming from the patient side, sensors, sleep, vital steps from the mobile, and data coming from the EMR, and all this is presented to the doctor. So the doctor sees both the things which come from the hospital, such as laboratory exams, etc., but also things that come from the patient. And this enables us to actually collect data outside the clinic boundaries. As you can see here, information is gathered. Now, an interesting way of presenting is to use what we call temporal abstracted language. Maybe this is the things that I want to show you a unique way. What is temporal abstracted knowledge? When a doctor is speaking, he's speaking in sentences. So I'm saying not the temperature is high, or the temperature is low. What do I mean by temperature is high? When I say the temperature is high, I abstract the data. I am having some cutoff, and beyond this cutoff, this is high, and below this cutoff, this is low. So we want to use the script that we actually write, so that the scripts will write the same thing just like the doctor. So let's say definition depends. For example, lactic acid is high for a patient hospitalized in a high ICU. If the patient is unstable, then the added value is 1, and if the patient is stable, the value is low. So once we have one sentence, we can have one sentence. We can do many sentences. For example, we can say when the BMI was high, then the temperature was low, then the lactic acid was high. So we create a language like the doctor is talking. So we abstract the data, and we can have the script that we write in the same way as the doctor is. So last thing I will show you is this is the most recent paper I think that we published. This is on patients with fibromyalgia, where we developed a new method for actually to cluster patients. So when we want to cluster patients, we want to see how many patients, how can we classify the patients into different clusters. So in this unique way, we wanted to develop a methodology to validate the optimal number of clusters of patients. So what we did is that we used the first step was to decide which algorithm is the best and what is the optimal K. K is the number of clusters. So as you can see here, there is a solution of 2 clusters, K2, where the algorithm decided that there are 2 clusters of patients. Each point is representing 1 patient. Then we have also a solution for 3 clusters, 4 clusters, 5 clusters, and each one of them was actually, we have done it with different algorithms. And we have seen, according to the metrics, which is the best algorithm to be used. So the first step is called clustering, is to choose the best algorithm. Here it was the K-means. This is one algorithm. The second method was to use distance measure. That means that there are, between each patient, there is a distance. And we measure this distance using different metrics. So here we use 3 different metrics called Silhouette, Kalinsky, and Davis. It doesn't matter, but in Silhouette and in Kalinsky, you have to have the higher is better, and Davis, the lower is better. And as you can see here, for the K-means, it was lowest in the Davis, which is good, and it was highest in the Kalinsky. So K-means is again a good solution because in 2 out of 3 distance measure, it was the best. Then what we did is we did iterations. What do we mean by iterations? If we take 100% of the data and we analyze the data, what happens is that this can be because of this specific data. So we have to divide the data again and take only 70% of the data, 50% of the data, and see if we get the same thing and if the data, the pipeline is robust. So we did it and we saw that it's 70%, and in full data, we gained the same information. And finally, all the methods that I've shown before, the clustering, the distance, the iteration and phases were syntactic. They were not semantics. So the next phase was the semantic phase, where we actually did statistics, and we saw that K-means was the best solution, and he divided the best solution when he divided the patients into 3 different clusters. As you can see here, there was a small cluster in red, which is only 20% of the patients, And what we saw that although there were no statistically significant differences between the clusters in gender and in age, those who were in the red cluster, and also there were no statistically significant differences except for one country of birth. And there were no statistically significant differences in the clusters in the numbers of years with the disease, but those in the red had higher level of pain, as you can see here. This is very, very interesting. They had less sleeping hours, less sleep quality, less quality of life, less treatment effectiveness. Now the green was a group in between, and the blue one was the healthier group. So here you can see those in the red had the highest number of rheumatological medical conditions. Those in red had more other conditions, non-rheumatological medical conditions. They had more sleep problems, those in the red group, in the red cluster. They had more traumatic life events. They had more symptoms. They had more functional problems. But in the number of painful areas, there was no statistical significant difference between those in the group that was in between, in the intermediate group. And they were gaining more treatment, except for one thing, exercising. They were doing less exercising. So finally, we ended up with the model that I want to also in this lecture mention. It's called SHOP algorithm. If you heard about SHOP, what SHOP is doing is actually helping us to understand, like a forest plot, what is more and what is less. Here you can see a SHOP. If something is more, let's take this feature, sum of functional problems, the prediction models tells me that if this is red, there is more chance that if there are more functional problems, there will be more of the target. Okay, so SHOP helps us to explain. Red is more, blue is less. And here you can see the three clusters, and then you can see the whole picture in one glance. More of the red, this is the thickest cluster here. More functional problems, more symptoms. This one is the healthy one. Everything is in the blue except for painful areas, and this one is in between. So this is the new pipeline that I explained to you, all these syntactic analyses and the semantic analyses. And I will not have time to discuss, maybe next time. I have so many other projects that I want, but I want to leave time for questions and for discussion. So I would like to thank you again. You can approach me, as I said, through my website. There is contact area, and through my LinkedIn. I want to thank you very, very much. And if you have any questions or discussion, I would love to have one. Thank you very, very much.
Thank you, Galit. Galit, my first question is for because the viewers today are also postgraduate students, young faculty. If they have interest in big data and they have to start, what are the 5 things would you suggest for them? How, for the beginners, basically, what would be the baby steps that they have to take? The first 5 things.
First of all, I suggest that you will create multidisciplinary teams, because it is very, very, very hard to do it alone. And one person cannot do anything. It's very, very hard. You see here a lot of my, it's always a team, because you have to have somebody with, I will show you among my team, for example. So we have professionals which are doctors, and we have medical information people. And we have students, and students are coming from different disciplines. This is a student for statistic and information system. This is a student, other students are, you see here, this is a PhD in information system. This is a nurse with an MPH. This is a student in information student. This is a medical student in computational medicine, and this is a dental student doing an MSc. So, first of all, create multidisciplinary teams because teams are extremely important. You have to have domain experts that will guide you and help you. Then you will have to learn how to work at least R, Python, and other things because we do classical statistics, but the world has changed, and this is not enough anymore to do these things. Third thing is, I think, is funding, getting funding, because to do this all hard work, it takes a lot of effort and time from business intelligent people who are actually creating the data, cleaning the data, students, laboratory, staff facilities. So this is step number 3, get funding. Fourth, I think that collaboration, international collaborations or other collaborations where you can use data that they are there to analyze it and to work with other people. And the five, and the most important thing for, I think, is publish. I think publish, publish, publish. They say if you don't publish, you vanish. So in order to have some kind of international acceptance and to go to the peer review process and see all these things that the reviewers tell you to do, because to work and not publish it, this it's not worth it. So I think these are the five most important things. And I would love to have collaboration. As you can see, nothing would happen without collaboration.
Absolutely. Thank you so much, Galit. Now I would request my team if they have any questions. Then we'll move on to the team on the webinar side also. Dr. Bharti.
Thank you. Hi, thank you, Professor Galit. I have a question here. When it comes to big data, when it comes to big data, how much big should be? Is there any limit for this? As you mentioned about the variety.
There is no limit for this, but as I told you, I work on data sets that are coming from, say, 1,000 to data sets, as I said, of about 1 million people. It depends on the disease I'm talking about. You do have to account while you are analyzing data what I call unbalanced data. For example, let's say that I have a cohort of 1 million people, but I have a disease that happens in only 1% of the people. So the data is unbalanced because only 1% of the people have it. And there are ways to overcome and to do things in the analysis, how to work on unbalanced data. This is a topic. I will not get into this. But it depends on the disease. Some of the entities are rare and can be, you have to have a huge cohort in order to study it. So it depends on you. And of course, I think that it's not only, as I said, the number, but the number can be a large number because it's a cohort study, and you have many tests for one patient. You see the patient 1 year, 2nd year, 3rd year, 4th year. So this is not only the volume of the patient, which is large, but the volume of the examinations or the variables that is large.
Thank you so much. And my second question is, when it comes to public health dentistry practice, we see the most of the developing countries are rural-based. Most of the population here, we have more than 50% of them are belonging to rural background. So when it comes to machine learning, maybe we don't have sufficient equipment, technology to support this. So then how do we include them in our data? How will they be part of our big data?
Are these patients, are there any electronic medical records in these rural areas or no?
No, there is no accessibility for all this.
So I think that this is why I was talking in the beginning of the lecture of how important is using applications. So you can reach out to these patients and collect data through sensors and through apps. For example, this app can be distributed all around the world. and it can be easily translated. So I think this teledentistry, and I think Harsh, as much as I know, is very much interested in the topic of teledentistry, is actually the future. In our last eOral Health Network, we had actually a meeting about how to use digital tools to help third world countries in the world. And we all agreed that only this is the only solution, because these digital tools can be very, distributed through, one professional who's coming to this area and using the data to collect data to have epidemiological service around the world. So now that people have these digital technologies, it can be used to approach large masses of data from people.
Thank you so much for the wonderful insight.
Thank you.
We have some senior faculty members also who are there attending the webinar. I request anybody has any query or any insight, some brainstorming from Dr. Galit, anything, I request you to kindly unmute yourself and share your views.
Okay, I will.
Good afternoon, Dr. Galit and Dr. Shashidhar Acharya. I am a public health dentist from Manipal. So I wanted to add something to what you said regarding the discussion about rural areas. So our government recently has a national database called as Aadhaar, where all biometrics of everybody and all the financial information is stored. So the government is now planning to make a health card, which is linked to this Aadhaar card, where all their health details are recorded whenever they visit any health facilities. So do you think such a data, if it is made, will it be helpful in generating big data?
Absolutely. I think this is a wonderful opportunity. And if this data can be accessible for you as public health dentist, I don't know if it is accessible because, it depends on the regulations and things, but this is a wonderful opportunity. I have been in the last IDEA meeting where they showed that the data of claims of insurance company were used, dental insurance company was used to analyze. So it's not exactly like medical records because this is insurance company data, which is mainly the codes for procedures, etc. But still, they can get a lot of information from this, and I think this is a wonderful opportunity. And you have to contact these people and see if they will have all the regulation and enable you to use this data to gain information in the dental field.
Thank you, ma'am.
Of course, when I'm talking about dental, I'm talking about craniofacial in general. I've not shown here, but I also have works about temporomandibular disorders, about oral lesions. We are working on the oral health. This is why eOral Health Network, we are working on oral health in general.
Yeah, thank you, ma'am.
Thank you.
So, do we have some more questions? So
So that's technical meeting. Questions.
Dr. Sumajashri, are you asking any question? No. Okay. So I think that brings us to the end of. There is a question. Professor Galit, there is a question from Dr. Vineet Vinay. He says that can you suggest some models for working on machine learning in oral cancer?
In oral cancer? Well, it depends on the task that you want to do. So if you want to do cluster analysis, Then I'll show you the things that we have done. Where we're using algorithms for cluster analysis, as you can see here, some of the algorithms. If you want to work on classifications, then you can use what I've shown you before. I've shown you XGBoost, I've shown you random forest, I've shown you other models that you can use. So it depends on the task that what you want to gain, whether you want to cluster the patient, you want to classify the patient, what do you want to do? That's my answer. So if you want to be more specific, we can, you can consult me specifically on here. You can see some of the algorithms that has been used, decision trees, others can be done also.
So he has his interest in deep convolutional neural networks. That's what he writes.
Yeah, okay. That can be also used. That can be also used. You are interested in classification. I understand. So classification is when you're taking something like, I want to see if he has this disease, yes or no. Clustering is that when you don't know what you're looking for, you only want them to cluster the data. So we can say how many clusters there are. So there are 2 clusters, 3 clusters, 7 clusters. So if you want to classify, you can use neural networks. You can use other algorithms such as I said, XGBoost, random forest, incubation gate, neural networks. All these things can help you to classify the data. But you have to have a registry where the data, because you can have what we call supervised machine learning and non-supervised machine learning, where the data is annotated or your data is not annotated. So you don't know the diagnosis, or you know the diagnosis because it is within the database. So it depends on what you have. I don't know which registry you're working on, but if you want to consult for more details, then I will be happy to help you.
Thank you. And thank you to all the participants who've joined us and who've made this webinar successful. Thank you, Galit. It was great hearing to all the work that you have done, the vast work that you have done. And we hope to collaborate in the future. And thank you all. That brings us to the end of this webinar. Have a nice day ahead. Bye-bye. Thank you.
Bye. Thank you very, very much. Thank you. Bye-bye.